So today we are going to have a discussion on how to identify these masks and what are the specific indications related to them. These are the simple questions like identify the oxygen delivery device shown in the image below and choose the correct statement about it. So until and unless you don't know the specific reasons or the specific features related to this mask and the apparatus, you won't be able to answer this question accordingly. So this is what we are going to talk about. If we talk about another sample question, the oxygen delivery device shown in the image is capable of delivering the high concentration of oxygen. Which of the following statement is true regarding this device? So they are asking about the mechanics related to this device in particular. So this is exactly what we'll be talking about. That means we will be talking about the oxygen delivery devices from their basics all the way up to their clinical applications. Whatever the mask to be used is dependent upon the two factors. One is that how much is the concentration of the oxygen that is required to be delivered, and second is how much of the volume of the oxygen that is needed to be delivered. Concentration of the oxygen is determined by FiO2, that means fraction of the oxygen in the inspired air, and the volume of the oxygen is determined by the flow rate, which is measured in the liters per minute. So that means it is dependent on two major factors. One is FiO2. Now you already know what is FiO2. It stands for fraction of inspired oxygen, which refers to the percentage of the oxygen a person inhales during breathing, either from the room air or through the oxygen delivery device. Like if I give you one example, that the normal air contains how much? 21% of the oxygen and rest 79% of the other gases. That means that the FiO2 of the room air is 21%. So why FiO2 is important? Because it determines that how much of the oxygen concentration is required in order to reach the lungs in a patient who is suffering from hypoxia or the respiratory failure, or the patient who might be requiring the ventilatory support, because this is the concentration that you can titrate based upon the requirements of the patient. The second one is the flow rate. Now, what is flow rate? Is the volume of the gas, particularly the oxygen, which is delivered to the patient per unit time, which is measured in liters per minute. So, as you know that flow rate is responsible for determining that how much oxygen is being delivered to the patient, because it affects the fraction of the oxygen in the inspired air. This flow can be changed based upon the apparatus used. This is what we were talking about, that what is the oxygen mask which is required to be given to that patient. It depends upon two factors. One is flow rate, which determines the volume, and the other one is FiO2, which determines the concentration of the oxygen. Now, based on this flow rate, these oxygen delivery devices can be divided into two. One is low flow system and the other one is high flow system. Low flow system is where the oxygen flows through less than the patient's inspiratory demands. That means patient also breathes in the room air. And the other one is the high flow, where the oxygen flow meets or exceeds the patient total inspiratory demand. That means FiO2 is more predictable and you have to provide it by a mechanical setting where you can control this FiO2. So these are considered to be high flow systems. So this is exactly how the oxygen masks or the delivery devices can be categorized into two systems. One is low flow and the other one is high flow. So under the low flow systems are the nasal cannula, the simple face mask, the partial rebreather mask, and the non-rebreather mask. So let's start with the first one, obviously, that is the nasal cannula, also known by the name of nasal prongs. Now, all of you as a medical student have seen that what are the nasal prongs, and you will be able to identify it very easily. Now, important point over here is that it is utilized where the flow rate is usually kept in between 1 to 6 liters per minute. That means, imagine if the patient is coming out of the operative room and you have to provide some amount of the oxygen to the patient in order to resuscitate, in order to stabilize that patient. That means in case of post-op, in case of early COPD, a patient who is suffering from mild hypoxia where not too much of the flow rate is required, then nasal prongs are used in those cases. where the approximate fraction of the inspired oxygen is in between 24 to 40%. So the patient is also inhaling, and this much amount of increased fractionated oxygen has to be delivered. Obviously, it has got some advantages, like it is comfortable and it allows talking and eating at the same time. Now, another one is the simple face mask, which is more commonly used in comparison to the nasal cannula or the nasal prongs. But the major difference over here is that the flow rate is higher. That means 5 to 10 liters per minute, which is required. Now, here the minimum of 5 liters are required to flush out carbon dioxide, and that is why it is not used in case of mild hypoxia, like the nasal prongs were used. It is used in case of moderate hypoxia. Now, in practice, we have seen that a patient out of post-operative room where a minimal support is required, let's say 1 liter per minute of the flow rate is given, very commonly by a simple face mask. But this simple face mask should be avoided in those cases because it will lead to a retention of the carbon dioxide. And where it has to be used, where at least 5 to 10, that means more than 5 liters per minute is the amount of the flow that is required to be delivered to the patient. And here, obviously, because you are increasing the flow, so the FiO2 delivered will also be increased from 40 to 60%. The advantage is it is having a higher FiO2, which can be delivered compared to the nasal cannula. And obviously, it will be having several of the disadvantages, like the patient cannot talk easily, the patient cannot eat, there will be fogging, there will be uncomfortable long term use. But the main difference in between the two is when the low fractionated of the oxygen is required, then you have to go for nasal cannula. But when a relatively higher fractionated oxygen is required along with the inspiratory uh, support by the patient himself, then in those cases, simple face mask has to be given. So normally, if now in that case, now you are aware that if you have a patient post-operatively in your wards who is just on a support of 1 liter per minute of the flow of the oxygen, then in those cases, this simple face mask should be avoided. Instead, what you have to give is the nasal cannula. In order to understand the third one, that is partial rebreather mask, you have to understand what is non-rebreather mask. So before actually talking about the partial, we will talk about the non-rebreather mask. Just try to understand what is the apparatus over here. What are the key components? Now, the first one obviously is the face mask. The face mask over here, which is covering the nose and the mouth. The second one is the reservoir bag. You can see that this is the reservoir bag over here, which has a capacity of storing 100% of the oxygen because it is connected to the oxygen pipe. Now, this is the oxygen pipe which is delivering the 100% oxygen to the reservoir mask. Now, there is one way inspiratory valve which is present between the mask and the bag. Now, this is the inspiratory valve which opens only during inspiration. That means when the patient inspires, then this valve open, and as a result of which, this 100% of the oxygen is delivered to the face mask. And it has a one-way expiratory valves on the side of the ports which allow carbon dioxide to escape, thereby preventing room air entry into the mask as well as into the bag. Now, this is the reason why it is called as non-rebreather mask. That means the patient is inhaling the entire 100% of the oxygen without intubation through this non-rebreather mask, which is having a single, that means one-way inspiratory valve. And when the patients were suffering from COVID-19, who were not unconscious, where the oxygen supply has to be given in high concentrations, then this was the mask which was most commonly used. So how it works now, you can very easily understand that oxygen flow, which is usually higher, that means 10 to 15 milliliters per minute, it fills the reservoir bag. And during inhalation, the patient breathes pure oxygen from the reservoir bag, which is pre-filled. It enters the lungs, and minimal or no room air goes into the lungs because of a single one-way valve that opens on inspiration. And during exhalation, this exhaled carbon dioxide exits through the side ports. So one-way valve between the mask and the reservoir, it closes, preventing backflow into the bag. So this is what the non-rebreather mask is. Now you can very easily understand and identify that the specificities related to these masks. The first one is the flow rate. Obviously, it will be higher. The FiO2 delivered is almost theoretically from 90 to 100%. That means the highest concentration of the oxygen that can be given without intubation or without ventilation. The structure is the presence of the mask, the presence of the reservoir bag, and the one-way valves. How it is working? Inhaled 100% oxygen from the reservoir, exhaled air via the side ports. Advantages: highest oxygen without intubation. This is what we are talking about regularly and repeatedly. And wherever there is a high demand of the oxygen, but the patient is conscious, is able to support breathing by himself, in those cases, it can be used, like in case of trauma, in case of ARDS, in case of myocardial infarction, in case where you are about to intubate the patient also, in those cases, it can be used. And the major difference in between the non-rebreather and the rebreather mask, now it becomes much easier or much simple for you to understand that in case of in case of partial rebreather mask, there is not going to be any one-way valve which is absent. That means when the patient inspires from the bag, now there is no one-way valve, so he is having a mixture of both the air from the oxygen flow, which is 100% of the oxygen, along with the air from the surroundings. That means this air in the bag is adulterated with the air from the surrounding, thereby concentration of this oxygen is decreased. So there is no such single mask. And second point is when the patient exhales, so there is also movement of the air back into the bag. So this bag consists of the air from the oxygen pipe that is receiving almost 100% of the oxygen, but also from the patient and the outside because of the absence of the single valve uh, in the bag. As a result of which, this air will be adulterated air with higher end of the oxygen concentration. So what are the basic differences in between the two? That the FiO2 delivered over here will be around 60 to 80 in case of partial, but it will be around 90 to 100 in case of non-rebreather. Is there a entry of the room air also? So yes, during inhalation. But here there is no room air entry because of the presence of one-way valve. Rebreathing of the exchanged gases, yes, partial rebreathing happens, but there will be no rebreathing. As far as the mechanism is concerned, you can very easily understand that the patient inhales oxygen from the bag plus some of the exhaled oxygen that he has done, which has entered into the bag. But here, the patient exhales only oxygen from the bag. Oh, sorry, the patient inhales only oxygen from the bag, and the exhaled gases, it exits through the valve. So these are the basic differences in between the two. The carbon dioxide clearances, obviously it will be less effective, it will be more effective in case of non-rebreather mask. The question on this non-rebreather mask for the purpose of its identification has been asked. The question on non-rebreather mask for the use in COVID-19 has been asked. And the third question, where without any ventilatory support, which of the following is having the highest possibility of providing the maximum FiO2 to the patient? Then in that case, the non-rebreather mask is the answer. That question has also been asked. So these are the questions which they have already asked. All right. Now coming on to the high flow rate devices. These were the low flow rate devices. Now the high flow rate devices. We have talked about the low flow rate devices like nasal cannula, simple mask, partial, and the non-rebreather mask. Now high flow rate devices are the Venturi mask, the high flow nasal cannula, and the mechanical ventilation. Now, first is Venturi mask because they have asked the question on the Venturi mask also. Now, first try to understand that what is the definition of the Venturi mask. Now, it is the high flow oxygen delivery device that provides a fixed and the precise FiO2 regardless of the patient's breathing pattern. And the principle it works on is the Bernoulli principle, which is also known by the name of Venturi effect. And that is the reason why it is called by the name of Venturi mask. You know what is the Bernoulli's principle? That if a gas flows through a narrow tube or the nozzle, then the velocity will be increased, but the pressure it drops, which causes entry of the or entrainment of the room air into the oxygen system. Now, as you can very clearly see that the structure over here, that each face mask is connected to an adapter or the nozzle. Now, how this Bernoulli principle is applied onto the nozzle? Each nozzle has a narrow jet orifice through which the oxygen flows, and the side holes. These are the side holes through which the ambient air it enters. Now, nozzles are color coded. We'll be talking about it, and with the each having a specific delivery of the fractionated oxygen. We'll be talking about it later. Now, try to understand this, that how it works. Oxygen flows through the jet nozzle at a high velocity. So velocity is high because the air is pushed through a small pipe or narrow tube. Now, as it exits the narrow orifice from here, it creates a low pressure zone. So here, low pressure zone is created. This pulls in air from the room. So as a result of it, from this orifice, the air from the room it enters through the side ports. And now the mixture of the air plus oxygen delivers a controlled fixed FiO2 to the patient, and the total flow exceeds the patient inspiratory flow, so no extra room air is entering during the inspiration. Now, as I told you that how this FiO2 will be fixed, because these nozzles are different, they are color coded, they are providing each delivering a specific FiO2 that we will be talking about later. Now, once you have understood the Bernoulli principle, it becomes much easier for us to understand about the Venturi mask. These are the air entrainment masks. The flow rate, it could be variable depending upon the adapter or the nozzle. The FiO2 delivered could also be variable. Now, the structure is that the mask with the color coded nozzles or the adapters working, it is based on the Bernoulli principle. That means the outside air is also entered and it delivers the precise FiO2 which is required for the patient. And the clinical use, it is usually used in case of COPD patient in order to avoid oxygen induced hypercapnia and the patient needing controlled oxygen. This question has also been asked, that what is the name of the mask, when they have given you the entire image and then you have to mark the answer as Venturi mask. Now, these are the color coded nozzles and the FiO2 chart. Like the lowest is for blue and the highest is for green, where the FiO2 delivered is maximum with the green nozzle and the FiO2 delivered is minimal with the blue nozzle. And this is something that you have to remember. There is a possibility that the questions could be asked from these things also. Then, not very much important, but because we have to complete the lecture, it is also required to be learned that what are high flow nasal cannula, the flow rate all the way up to 60 liters per minute, FiO2 delivered all the way up to 100. The structure is heated, humidified oxygen via large nasal prongs. Advantages are it is comfortable, it reduces the work of breathing, washes out the dead space, and clinical use in case of COVID-19, pediatric bronchiolitis, and early respiratory distress syndrome. So, high flow nasal cannula system is also available. And something that you already are aware of are the non invasive ventilatory devices, which are BiPAP and CPAP. The major differences in between the BiPAP and CPAP is that CPAP is a continuous positive airway pressure, while BiPAP is a bi-level positive airway pressure. Now, what is the basic difference in between the two? The variance in the pressure levels. In case of CPAP, it is providing a single continuous pressure. But here we are having two levels of pressure. That means inspiratory and expiratory pressures are different. How? That during inspiration, this BiPAP is having a higher pressure, while during expiration, it is providing a lower pressure in order to wash out more and more of the carbon dioxide from the lungs. While in case of CPAP, it is same as expiration and same for inspiration. The pressure remains same. So, as far as the patient effort is concerned, the patient must initiate the breathe in case of CPAP, while in case of BiPAP, the patient can initiate and even the machine can also assist because of these pressure changes. Ventilatory support, it does not assist ventilation, only oxygenation. It is only for the provision of the oxygenation to the patient. But here, it is responsible for receiving the ventilatory support, and it helps out blow off carbon dioxide by the mechanism that we have already talked about, with a variation in the inspiratory and expiratory pressures. FiO2 control could be variable. It is variable connected to the oxygen source. The mechanism, it keeps the alveoli open during all phases of breathing because of the continuous pressure which is applied to the lungs, while it assists in both oxygenation as well as ventilation because of the pressure changes. Both of them are non-invasive. So these are the basic differences in between BiPAP and CPAP. And FiO2 delivered all the way up to 100%. This working, we have already talked about that what are the pressure changes. Advantages, that it avoids intubation, improves ventilation and oxygenation. It is used in case of acute respiratory failures, COPD, exacerbation. But one more thing which is very, very important for you to remember are the contraindications. The contraindication, wherever there is a risk of aspirations, if the patient is unconscious, if the patient is too much sedated, if the patient is wherever there is a risk of aspiration, in those cases the endotracheal tube is required for provision of the ventilation. That means you have to go for invasive mechanical ventilation. So invasive mechanical ventilation is achieved by either the endotracheal tube or the tracheostomy tube based upon the indications for that particular patient. And it is obviously used in case of severe respiratory failure, post-surgery, ARDS, trauma, coma, means multiple of the reasons wherever there is a requirement, wherever the patient cannot ventilate or oxygenate. Now, coming on to the comparison table of what about the masks we have talked about. The precise FiO2 is not given in any of these low flow devices, while precise FiO2 can be given by the high flow devices. And this is something that we have already talked about. In a nutshell, this table summarizes of what we have already learned based on the lecture provided. In order to conclude our topic, understand the FiO2 and the flow rates before selecting the oxygen devices which are required for that patient. Match the device to clinical condition and severity of the hypoxia, then only it will prove beneficial to the patient. Otherwise, there is a possibility of mismatch. Use oxygen judiciously because although it is life-saving drug, but it is having risks. Now, based on what we have learned, quickly let's talk about some of the sample questions. It would become much easier for us to understand and identify and mark the answer correctly. A 65-year-old COPD patient requires oxygen therapy. Which device allows the most precise control of the FiO2? And among the options provided, as we have already talked about, the most precise control of the FiO2 is provided by the Venturi mask because it delivers fixed, precise fraction of the oxygen, like 24 to 60%, using color coded adapters. That is why it is considered to be ideal for COPD patients who are having hypoxia. Second question is a non-rebreather mask. It delivers high fraction of the oxygen because, and the correct answer for this question is because it has one-way valve which is preventing room air entry. This is something we have talked about because one-way valve on the masks and in between the bag to ensure near 100% oxygen is inhaled with minimal room air, although this value of 90 to 100% of the FiO2 is theoretical. Practically, it varies around 70 to 80% because of some adulteration. But yes, it is responsible for providing the highest fraction of the oxygen in a non-ventilated patient. Next question. Which of the following statement about the partial rebreather mask is true? So answer for that question, that it allows partial rebreathing of the exhaled air because of the non-provision of the one-way valve, unlike NRBM. So this partial rebreather mask, it allows the patient to re-inhale the oxygen-rich portion of the exhaled air which is present inside the bag. Now, in which of the following devices does FiO2 vary based on the patient's breathing pattern? And the answer for that question is nasal cannula, because devices like nasal cannula are the low flow systems and the FiO2 varies with the tidal volume and the respiratory rate. And rest all of them are the high flow system devices where there is no variation. You have to set the FiO2 in those cases. Next, which of the following statement about CPAP is incorrect? And the answer for this question is that it assists in carbon dioxide elimination. This is the function of BiPAP, not the CPAP. Now, CPAP does not support ventilation. No pressure changes between inspiration and expiration. So it does not help in carbon dioxide removal. Rest of the options are correct, like it provides continuous positive airway pressure, it improves oxygenation, it is used in OSA and pulmonary edema. A patient in hypercapnic respiratory failure, that is type 2, due to COPD is best managed initially with, then the answer for that question is BiPAP, because here BiPAP provides inspiratory pressure support which improves the ventilation and is responsible for flushing out the carbon dioxide, which is essential in case of type 2 respiratory failures. So BiPAP is the best answer for this question. Which of the following oxygen delivering devices provides the highest FiO2 without intubation? This thing we have already talked about multiple of the times. Then the answer for this question is non-rebreather masks. The principle behind the Venturi mask is Bernoulli's principle or the Venturi effect, and we have already talked about it in details. The HFNC, that means high flow nasal cannula, it delivers oxygen at high flow rates with humidification. I mean, less likely that the questions are going to be asked on this, but if at all, these are the kind of the question that could be kept in your examination. Now, which device gives positive pressure throughout both inspiration and expiration? And the answer for that question is CPAP. Just now we have talked about that CPAP is responsible for providing continuous positive pressure during both inspiration and expiration, thereby improving alveolar recruitment and oxygenation, but no ventilation. So all the best for your future examinations. Thank you very much for listening the lecture. Hope you have learned something new. In order not to miss any update, please join our Telegram group. The link is provided to you in the description. All the best.